Hello, my name is Stefan Hartmann. I'm a physician assistant, and today we're going to be going through a case study with a review of the supporting literature and theoretical pathology in the treatment and prevention of COVID-19. Here's a little disclaimer: this lecture is not to be used as medical advice. Please visit your local physician assistant for their medical expertise. Let's get on with the case here. So the case is a 60-year-old male who arrived to my urgent care at 9 p.m. with difficulty breathing, fever to 103, oxygen at 90%. He had bronchi diffusely on exam. He was tachypnic. He seemed quite uncomfortable. Significant history of hypertension, sleep apnea, prostatomegaly on an ACE inhibitor, lisinopril, and alpha blocker, alfuzosin. He tested positive with COVID-19 at a Florida State facility via positive PCR about 1 week ago. His PCP suggested he take Tylenol ibuprofen for the fevers that he was having, dosing that every 6 hours. I diagnosed this patient clinically with COVID-19 ARDS pneumonia. New score of 8 using MD Calc's algorithm. It advised continuous monitoring, possibly even an ICU setting. The chest x-ray was skipped since it would not change management and would needlessly expose the radiology staff. Medication management. The Tylenol ibuprofen were discontinued in this patient. While these are easily obtained over the counter, they're not benign. Tylenol can damage the liver in excess, as can ibuprofen. I reviewed here on the link, you can click that, on how ibuprofen and NSAIDs can even inhibit muscle recovery and exercise training programs. So not entirely benign medications, often used as pain relievers, and patients use these to reduce fevers, but I'm of the mind that fevers are not a disease state and don't necessarily need to be treated. These drugs should usually be used just, if you're having bad symptoms, you can use one. And this is kind of what I advise for the patient, just to use these really as needed, not on a regular basis. The ACE inhibitor lisinopril was not discontinued. There's multiple medical organizations that are currently not recommending to discontinue them in the case of COVID. There are some studies being done to see if ACE inhibitors or ARBs, angiotensin blockers, are harmful or helpful in COVID, but at this time we do not know. This patient wasn't hypotensive or dizzy, so it was not halted. The patient was also going to continue the BiPAP he had at home, since he said it was helping him breathe at night. Let's talk about one of the first steps of my treatment algorithm. It's lifestyle treatment for COVID-19. I believe that glycemic variability is an underrepresented category of morbidity and mortality in COVID-19 patients. We can look at this 7,000 patient study by Zhigang and Cheng. You can click on the link there and find the site in the works cited at the bottom of this PowerPoint. They identified that patients with well-controlled blood glucose had a 98.9% survival rate, but those with poorly controlled blood glucose had a much higher incidence of death. Glycemic control is a very large topic that I'm currently researching and presenting on. I would recommend it for this patient post-meal exercise, so aerobic or anaerobic as tolerated, outside ideally under the sunlight. Aerobic being like a simple walk, anaerobic being more like muscle building exercises, so strength training. I also advised a low carb diet, so basically grass-fed beef, wild-caught fish, organ meats, greens. Turnip greens have great flavonoids and can help inhibit the ACE receptor, which is, as we'll see in this PowerPoint, quite a big mechanism of pathology as COVID enters the cells. Let's go on to the next slide here. Dexamethasone. This patient was having quite severe respiratory symptoms. I placed him on dexamethasone at 6 milligrams for 5 days and then tapered him over 12 days. The recovery trial is actually quite a significant trial that came out recently, showing that low-cost dexamethasone reduces death by up to 1/3 of hospitalized patients with severe respiratory complications of COVID-19. This was done by Horby et al. They're currently still doing multiple arms of this recovery trial, and I recommend always looking at their updates on this. You can find the citation to this at the bottom of the document. Dexamethasone is a well-known steroid drug. It does have risks of immunosuppression and hyperglycemia that is common with all steroid drugs, but the benefit outweighed the risk in this patient. This patient, I also placed him on azithromycin, 500 milligrams for 5 days. This is actually a particularly high dose. Some of the studies say you can do just the regular dosing of this. I did this for a couple reasons. One, to cover for bacterial superinfection. It's possible he did have a bacteria also, plus assumed COVID-19. There's a second reason. Supposedly, azithromycin has anti-inflammatory effects. It can actually reduce the cytokine and chemokine release, which we'll see later is a very important mechanism of pathology in COVID-19. Azithromycin has also been used for many, many years in COPD patients with COPD exacerbations and bronchitis, and these patients actually seem to do better on azithromycin for assumed reasons that it is anti-inflammatory. It's not always necessarily that these patients have a bacterial pneumonia and azithromycin fixes that, but these patients seem to do better on it with whether they have a bacterial infection or not. There's a third reason. Supposedly, azithromycin has shown good results in vitro and antiviral properties in other viruses like Zika and Ebola, and even COVID-19. This is according to Damel, Verhoeves, Wang, Lini, and Corrigan. There's a couple mechanisms for why this might be a beneficial drug in COVID-19 and these viruses. Obviously, in vitro data isn't the best, but it's what we have at this moment for azithromycin. Let's go to anticoagulation. I think this is a hugely underrepresented category of morbidity and mortality in patients. I actually did a whole PowerPoint on this. You can click on the link here and review that. I actually discussed this back in April with Clark et al., who is a researcher, and we were discussing, how are they determining if these patients are actually dying of ARDS, pneumonia, or if they're dying from microvascular or thrombotic complications of COVID-19. Unfortunately, at this time, and still currently, there's not a whole lot of autopsy studies being done, so we can assume that the patients maybe are dying of anticoagulation. Clark et al. Actually recommended putting patients up to 40 milligrams of enoxaparin, a low molecular weight heparin drug, in the ICU setting. This is actually quite a strong dose. I put this patient on aspirin, one, because he had been on it in the past and it agreed with him very well, and he had stopped it for unknown reasons, so I restarted him on aspirin. Although it's not an anticoagulant, it's just an antiplatelet. I think this was a fine place to start at 325 milligram daily for about a week, and then I was going to continue on an 81 milligrams for about 2 to 3 weeks afterwards at least. There's several reasons for why COVID-19 causes microvascular complications, MIs, strokes, and venous thromboemboli. And Bigdelli et al., as you can see in this diagram, goes into some of those mechanisms in his article. And you can also look at my own article on this as well on the link. Let's go on to glutathione. I asked this patient to start glutathione 600 milligrams twice daily for 7 days. Glutathione is very interesting to be used here in these sort of patients. We know that it is found lower in elderly, in smokers, in males, and those who have comorbid conditions. All of these categories are patients who we know suffer from COVID-19 and have increased risk of death. Similar to the theory on vitamin D deficiency being being lower in those who suffer from COVID. Low glutathione is hypothesized to cause more suffering in COVID. It's possible that these are just markers for poor health and that supplementation would do nothing to help improve outcomes, but vitamin D and glutathione, I believe, are quite safe and can be supplemented. We will go into why in a little bit. Let's go to slide 10 here. So glutathione, Polnikov, a Russian researcher, was looking at patients who have low glutathione deficiency and their reasons for having worse outcomes with ARDS. Those with chronic disease, cigarette smoking males, low glutathione intake, so those who are insufficient consumption of fresh vegetables, fruits, those sort of things. There's many reasons as to why glutathione might be low in these patients, but we know all these sort of patients suffer more with COVID-19. So glutathione is a tripeptide composed of glutamate, cysteine, and glycine, and it has protective mechanisms in illness. The common denominator in all these COVID-19 patients is their comorbidities. Men die at a rate of 2.4 to 1 compared to women. Possible reason for this is that men use glutathione more rapidly in illness and thus become deficient. Glutathione is currently being looked at as a method to inhibit influenza viral replication. The benefit of using glutathione to fight a virus as compared to using an antiviral like oseltamivir or remdesivir is that viruses often will mutate to become immune to such drugs, while the only limitation with glutathione is that the dose required to be beneficial is difficult to determine. It is suggested that very high doses are necessary. In one study of 2 COVID-19 patients, they used 2,000 milligrams of glutathione. It is known also that elderly have less glutathione than young people. A study supplemented elderly with cysteine and glycine for 14 days and found that doing this brought the elderly's glutathione levels to that of the younger controls. This was done back in 2011, not for COVID, but for some other things. So glutathione, a safe drug to use, relatively, compared to anything else that we're talking about here, like dexamethasone or azithromycin, and may prove quite beneficial, at least theoretically, in COVID-19 patients and possibly many other disease categories. Hopefully we'll see more literature on this in the future, but glutathione, a very interesting one to watch. I actually suggest this patient take the liposomal version since I believe it's more bioavailable, maybe more effective. Let's go to the slide 12. L-arginine. I asked him to supplement this one. I don't think this patient actually ended up taking this, but I believe glutathione and L-arginine work synergistically together. While glutathione is a tripeptide thiol antioxidant, arginine is a conditionally essential amino acid that functions as the obligate substrate for the nitric oxide production through actions of the nitric oxide synthase enzymes. So in this hypertensive patient, L-arginine would have been helpful. As explained below, you can see that, let's see, hypertension may depend on multiple factors. Among them, it is relevant to cite the activation of the renin-angiotensin system, mainly by renin overexpression secondary to low vitamin D, the decreased activity of eNOS, so nitric oxide, and the decreased levels of glutathione, so GSH, as already described for diabetes. The combination of low glutathione and low nitric oxide leads to higher calcium influx in the vessel wall and in the smooth muscle with vasoconstriction, as demonstrated also in animal models. Since hypertensive patients, the low levels of glutathione are often accompanied by a decrease of companion enzymes and increased lipid peroxidases. The prevailing hypothesis is that glutathione decrease is due to a burst in ROS, so reactive oxygen species production, secondary to an inflammatory process. It has been demonstrated that glutathione depletion induces chronic oxidative stress and causes hypertension in normal rats. This is accompanied by inactivation and sequestration of nitric oxide by reactive oxygen species, leading to diminished nitric oxide bioavailability. So supposedly supplementing with L-arginine, which actually a lot of bodybuilders do, a lot of fitness enthusiasts do, to increase nitric oxide, might be helpful, especially in a hypertensive patient. Let's go on to vitamin D. This patient was placed on 30,000 units for 3 days, and then I asked him to do 10,000 units daily for maintenance. Now, studies have found an association, again, between vitamin D and suffering from COVID-19. It may be that vitamin D in these studies just represents a marker for poor health, and it's unclear if vitamin D supplementation actually changes outcomes. But several mechanisms describe that it may be helpful. So let's go through a couple of these mechanisms here. So if you look at vitamin D from glutathione perspective, vitamin D suppresses the cytokine activation and enhances gene activation related to glutathione, so it may help bolster the glutathione levels. And there's overwhelming bulk of it's the safety of glutathione. You may think, okay, is vitamin D safe to use, right? And often I get this back from people like, it can be dangerous, increase calcium. So we looked at one study that looked at this, right? The overwhelming bulk of clinical trial evidence supports the conclusion that a prolonged intake of about 10,000 units of vitamin D likely poses no adverse risk in almost all individuals in the general population. So, a bit of supplementation, maybe 30,000 is a bit high for 3 days, but after that, 10,000 units daily is kind of a decent maintenance dose. I myself and my sister, we take this every day without adverse effect. It may help, so let's see. Granadol describes several mechanisms through which vitamin D may help in COVID-19, such as inducing cathelicidins and defenses that can lower viral replication rates, reducing concentrations of pro-inflammatory cytokines that produce the inflammation that injures the lining of the lungs, leading to pneumonia, as well as increasing concentrations of anti-inflammatory cytokines. Okay, very interesting on vitamin D there. Vitamin C. I supplemented this patient with 6 grams of vitamin C for 7 days. It's safe, it's cheap, and it may even help in severe cases of COVID, and we'll get into why. Severe late forms of COVID-19 are due to cytokine storm involving IL-6 and ET1. Vitamin C, especially at high doses, can reduce mediators such as those. COVID-19 pneumonia seems to be a lung injury caused by hyperactivation immune effector cells, and high doses of vitamin C may result in immunosuppression at the level of these effectors. Therefore, intravenous high doses of vitamin C could be a safe and beneficial choice of treatment at the early stages of COVID-19. The Citrus A trial recognized that hospitalized ventilated patients do not improve with high doses of IV vitamin C. So I believe that once these patients do get to that setting in the ICU where they're very, very sick, there's not a whole lot that does change outcomes. So early supplementation before they get on the ventilator, where they get very sick in the ICU, would probably be the most useful way to treat these patients with these sort of methods, with supplementations, because pretty much every study shows that once they get that sick, nothing really helps. Let's go on to zinc. This patient was advised to take 75 milligrams twice daily of zinc, and there's multiple mechanisms for why zinc may help inhibit SARS replication and reduce this inflammatory response. There was a beautiful article by these 3 researchers, Galny, Rink, Azhukova, Ashner, and Gritsenko, and they say that it decreases activity of the ACE2, as the ACE2 is a receptor that the COVID virus uses to enter the cells. It improves antiviral immunity by upregulation of interferon alpha production and increasing its antiviral activity. It has anti-inflammatory activity by inhibiting NFK signaling and modulation of regulatory C-cell functions that limit the cytokine storm. There's reduced risk of bacterial co-infection by improving mucociliary clearance and barrier function of the respiratory epithelium, as well as direct antibacterial effects against Streptococcus pneumonia. So zinc, very well tolerated. This patient took 75 twice daily. NAD precursors such as nicotinamide riboside and 5-nicotinamide mononucleotide and niacin B3. You've probably heard of niacin. I asked this patient if he would supplement with a specific brand that I know of, NAD Plus Booster, 300 milligram daily or twice daily. I actually use this one myself. NAD Plus precursor supplementation is discussed in the longevity community to slow aging, fight the harmful effects of metabolic disease, and to improve lifespan. It is thought that NAD Plus will likely be depleted as the body fights COVID, as is the case with tuberculosis. This is from Pagello in 2018, and in streptococcal disease by Hizet in 2020, and HIV infection in Murray. In all those cases, NAD is known to be depleted. So it's quite possible that NAD is depleted as well in COVID. Elderly COVID-19 patients are at real risk of complications due to impaired immune function, cytokine storm, and defective respiratory function. Administration of anti-aging immunomodulating factors like nicotinamide adenine dinucleotide, or NAD+, can minimize these changes through its potent immunomodulation longevity effects. NAD+ has direct inhibitory effect on PARP1 and can prevent pro-inflammatory cytokine overactivation. Increasing NAD+ level will also result in stabilizing telomeres and has a positive impact on immune cell function. This was a hypothesis from Omran and Amaliki very recently they were thinking about using this as well in COVID-19. Obviously, there's no studies on this, but something that can be very safely used in patients. Let's talk about melatonin. I actually came across this from Eddie Joe MD. He was posting about this on Instagram. So I went and looked into studies, and wow, quite impressive what a little melatonin can possibly do and how it's being used currently. It's actually being used in some ICU settings right now. They're dosing these patients pretty highly on it. They're doing like 200 milligrams twice daily for 7 days in some cases. I had this patient just take 50 milligrams at bedtime. Later I found out that he was already taking it, but he was taking only a small dose, about 6 milligrams. Melatonin, a well-known anti-inflammatory and antioxidant molecule, is protective against ARDS caused by viral and other pathogens. Melatonin is effective in critical care patients by reducing vessel permeability, anxiety, sedation use, and improving sleep quality, which we also know is going to be critical in recovery from any illness. Let's see, which might also be obviously better for clinical outcomes. Notably, melatonin has a high safety profile. There's significant data showing that melatonin limits virus-related diseases and would also likely be beneficial in COVID-19 patients, Zhang et al. 2020. Let's see. It is noteworthy that high levels of melatonin play positive roles in health and aging. Melatonin, a well-known chronobiotic, is also a promising adjunctive drug for viral infections due to its anti-inflammatory, anti-apoptotic, and immunomodulatory, powerful antioxidant properties. This is from Ryder et al. 2020. There is quite an interesting mechanism or theoretical model here. You can see there in the slide. I won't go into it. It's very complicated of how melatonin might help, but I'd say it's a relatively safe drug to use in these patients. Hydroxychloroquine, I didn't use this in this patient. At this time, there's only theoretical literature supporting its use, such as inhibiting entry into the cell through the ACE2 receptor, which we've discussed. Several other of these little supplements that I use for this patient are doing. It has been used for years to prevent malaria and treat some autoimmune conditions. Since COVID causes an immune overreaction, hydroxychloroquine theoretically could be of use. The medicine also has some side effects. I used to think that it had, back when I just started, I used to think hydroxychloroquine was quite dangerous, but then as I saw more patients being on it and tolerating it very well and actually needing it to just give out their daily lives, in rheumatoid arthritic conditions, I consider it a relatively safe medication. A non-randomized French clinical trial of 36 patients in a hospital setting noticed a 17% virological cure at day 6, and we'll get into that in a minute, when treated with 600 milligrams of hydroxychloroquine compared to only 12.5% in the control group. Adding azithromycin, there was a 100% viral cure rate. Now, this viral cure rate, what that was just testing negative via another PCR swab. As an endpoint, I'm not sure how significant that is. It appears that you stick a swab up someone's nose, and 6 days later, they could be negative if they supplement with these two drugs. If they don't, it would take longer. Or whatever. A large French retrospective study of 1,000 COVID patients studied hydroxychloroquine 200 milligrams 3 times daily for 10 days and azithromycin 500 milligrams on day 1, followed by 250 milligrams for the next 4 days. This was by Million et al. They gave patients both drugs just based off a positive PCR, regardless of symptoms. Good clinical outcome and virological cure were obtained in 973 of the patients within 10 days. Oh, that's pretty big, right? I think. There was no cardiac toxicity reported. They defined poor clinical outcome by either death or transfer to the ICU or hospitalization for 10 days or more. The key takeaway with the study was that early treatment of azithromycin and hydroxychloroquine might be helpful. I suspect that starting these patients later in the ICU might not be helpful. It's an interesting study. The problem was that who they were treating with this, it was just based off of symptoms and it was based off a positive PCR regardless of symptoms, so it's quite possible that these patients would have done fine either way. But the most interesting part was that there was no cardiac toxicity reported at this dosage, at least, which is kind of what I've I've seen in my own patients who are on this is that it's not toxic as some media reports would lead you to believe. Unfortunately, once they get into the hospital, it is absolutely of no use. The recovery trial, which we discussed earlier with dexamethasone, there's another arm of this trial, and they looked at hydroxychloroquine, and they identified that it has no use. But I think with all these things, if you just look at them myopically, they're going to have no use. COVID is a dynamic disease. It affects the respiratory system. It affects the vascular system. If you just think about treating the patient with hydroxychloroquine and you ignore diet, you ignore exercise, you ignore supplementation when they may be deficient in glutathione, zinc, they're probably going to do poorly if you look at it myopically with one drug. You need to look at the patient through a larger viewpoint, a larger lens. Let's look at the takeaway points in descending order of significance. So glycemic variability, that would be my number one, right? So it's a completely under-recognized category here. We often will tell a patient to take a drug and send them home, and we don't think about what they're eating. Are they going home and they're drinking wine? Are they going home they're smoking? Are they going home they eating a bucket of ice cream? What's their lifestyle like? Obviously, if they're doing all these sort of things, they're gonna suffer longer. You're smoking, you're drinking alcohol, you're eating ice cream, you're gonna suffer longer. That's just my opinion. I can't prove that or not, but you have to kind of look at the patient from a whole group. What are they doing at home? You can put them on a drug or two. Will it make a difference if they're doing this sort of thing? If they're already sick, they're not taking care of themselves? You need to counsel the patient on lifestyle. Dexamethasone, probably the only proven drug to be beneficial in severe COVID cases. Good job to the recovery trial for discovering this. Very helpful. Azithromycin, I would say, would be my go-to for bacterial lung superinfection. Theoretically might help in COVID-19 as well. Glutathione, you gotta think about this in your elderly patients who are suffering with COVID. They're likely going to be deficient in glutathione, and supplementing might help in those suffering with COVID. Anticoagulation, you have to think about the risk factors in your patient. Do they have risk for cardiac incidents, vascular incidents, and consider, are they taking an anticoagulant already? Great. If they're not, do you want to put on one? Do you want to put them on an antiplatelet? Melatonin, zinc, vitamin C, NAD plus boosters, vitamin D, L-arginine are generally really well tolerated, have great safety profile, and might help in COVID-19 illness. A lot of people are deficient in zinc. A lot of people are deficient in vitamin D. You test these things. You can do a vitamin D panel pretty easily for like $10. Pretty much all the patients I see are deficient in vitamin D, and I live in Florida here. It makes no sense. It's probably from the diet. It's my assumption. But also people work indoors a lot. They're not getting the sunlight. They're not out, surfing and playing tennis. And probably gonna be deficient in vitamin D. I mean, you can get vitamin D naturally through wild-caught salmon, mackerel. Obviously, sunlight. We want to protect ourselves from the harsh fluorescent sun. So you might want to look at diet more. But supplementing with 10,000 units vitamin D daily. My sister does that. It's not a bad idea. Medication management, there's multiple medical organizations that suggest continued use of ACE-ARBs. I'd still look at your patient. Are they hypertensive, dizzy? If that's the case, they might have to go off it. You don't want your patient passing out because they're hypertensive. They're sick. Their blood pressure is going to be a bit lower. But these organizations, they say you don't necessarily have to take them off ACE-ARB if they have COVID. Tylenol, ibuprofen, every 6 hours. No. Use it as needed. There's no need to regularly take this every 6 hours. It's not going to treat the infection, and it's going to harm your kidneys and liver if you take too much of it. I had a patient recently who was taking so much of it. She also was suffering with the COVID, and she was taking 1 gram 4 times a day. She'd been doing that for 10 days. I was like, wow, that's a lot. Just slow down on that a little bit. And she was still having fevers, even with that. And I did put her on medication regimen like this, and her fever actually stopped the next day. Take that for what you will. Hydroxychloroquine might be helpful. I don't really see why there's such a campaign against it. It's been used for years in malaria. It's been used for years in autoimmune conditions like rheumatoid. It might work. Obviously, you have to look for drug-drug interactions, as with everything. You're not going to put a hydroxychloroquine patient on, a benzodiazepine and maybe some other QT prolongation drug. You can't do that. You have to still look for drug interactions. Um, I would say it shouldn't be so politicized. It might help. It might not help. It should be up to the patient and the provider. Let's talk about my follow-up on this patient. I was actually calling him quite regularly. I called him back on day 5. He was still on the azithromycin and dexamethasone. He was starting to feel better, and his fever had stopped. He stopped taking the Tylenol, and he was still having fevers even on the Tylenol. But once I stopped him from taking the Tylenol and got him on the dexamethasone and azithromycin, his fevers actually stopped. I'm not sure why. Maybe his fevers would have stopped anyway, even if I did nothing. But who knows? He had not gotten the NAD plus and glutathione, but he was taking the zinc. He was taking the melatonin. He was taking the vitamin D. He said he still couldn't wait to breathe normal again. He noted that he got another PCR swab 2 days ago. I told him that I wouldn't be surprised if he would be positive for 3 months, since the Korean Center for Disease Control had found that to be the case with his age category. Yeah, they actually they looked at like 500 patients who were retesting positive via PCR for COVID. They watched these patients. They actually found that none of them transmitted the virus after they had recovered from it, despite being positive for PCR. There's also something a lot of people don't know about, is that once you recover from it, even if you are positive for 3 months, the Korean CDC didn't find one case of someone transmitting that re-positive to someone else. So I think that's because the epithelial cells on the nasopharynx, they regenerate at an average rate of 3 months. So you stick a PCR swab up there, and you catch a cell with an RNA virus in there. You stick it in a machine. The machine doesn't know the difference between an active virus and an inactive virus. So it's going to spit you back a positive, even if you've recovered from it. So I called back on day 8 to check in, and he said he felt largely back to normal. He asked me if he could go back to golfing since he tested negative for COVID-19 on repeat PCR. Actually quite surprised by this, that he was negative on repeat PCR. Maybe it was just, someone didn't stick the Q-tip back there far enough. Alternative is that maybe the azithromycin did decrease his return to retest negative. I met again with this patient around day 15. He walked into the office. He looked great. His color was great. I listened to his lungs. No rhonchi. It was amazing. Complete return around. He noted that the BiPAP had helped him during the worst nights of the COVID illness. He said it helped him breathe. And that was this patient's story. Whether that works for all patients, probably not. But he was a great candidate for this. He's very compliant with the whole regimen, very interested in it. And here you can find all my work cited in this. Quite a lot of articles I went through to look into all the recent treatments. Obviously, there's going to be new ones. I saw a recent one recently using hydroxychloroquine in healthcare workers who were exposed to COVID-19 illness. They didn't find any difference in outcomes between the placebo arm and the hydroxychloroquine arm. So it was a negative trial for hydroxychloroquine. But again, these were like young, healthy healthcare workers. You put them on hydroxychloroquine, they probably would have done fine with or without it, which kind of the study did show. Like, if you're young and healthy, you're going to do fine. It's the patients who are older, who do have comorbid conditions, that suffer more from COVID. These patients we have to focus on, and we have to try to, figure out how to help them. And it's not enough to sit back. It's not enough to say there's no data. There is some data out here. It's mostly theoretical. If you look at the mechanisms, you can think about supplementing these patients with one or more of these things, and focus on the diet, focus on the exercise, focus on a healthy lifestyle. That would be kind of my takeaway from all this: is diet, exercise, supplementation, keeping your immune system healthy. That would be probably the best way to fight COVID. I wouldn't put all my what's the term for this? Put all my horses in one pen for remdesivir or hydroxychloroquine to work. If just one drug isn't going to fix it. COVID is a complex disease. You have to think about it from a holistic perspective. Think about how to improve the patient's health from the roots up. And I think you're going to have better outcomes with your patients. So yeah, that's my case here. I hope you all enjoyed. Bye.